All right, welcome everybody to this week's Zoominar. Today we're fortunate to have Katie Brown and Gillian Haney. Katie Brown is the state epidemiologist for the state of Massachusetts, also the state's veterinarian. And Gillian Haney is the director of the Office of Integrated Surveillance and Informatics Service. So two perfect people to ask about what's happening in Massachusetts and what we did and what we're doing going forward. So thanks again for joining us. We're all very excited to have you with us. So I just want to quickly let you know that this is an audience of data scientists. So you can, if you want, you can be technical in your responses in terms of epidemiology and statistical concepts. So don't be shy about answering in technical terms. Most of us understand that language. So my first question is if you can tell us a little bit about what your office does, what your offices do, and what you two do, and you can go whatever order you prefer.
Great. Well, why don't I start with, I'll share a slide or two.
Thanks.
To sort of orient us where Katie and I work within the Department of Public Health. So we work for the Department of Public Health in the Bureau of Infectious Disease and Laboratory Sciences. And we're a very large bureau that is primarily housed at the State Public Health Laboratory, which is in Jamaica Plain. And we have various divisions and offices in addition to the State Public Health Laboratory located there. My office is here, the Office of Integrated Surveillance and Informatics Services. And we are primarily like a data coordinator for all of the other divisions within our bureau. Our bureau is tasked with doing case investigation and follow-up and surveillance of about 90 infectious diseases. And we oversee—
Did you say 90? 90?
So wow. Here, I have a nice slide. Hopefully you see that.
Gillian, do you want to put that in, presenter mode? There you go.
How's that?
Very nice. Now we can read it.
Okay. So we have a mandated 24/7 response, and I think like 90 notifiable diseases, including everything from measles, coccal disease, sexually transmitted infections, and of course COVID-19. We work very closely with the 351 local boards of health across Massachusetts. Massachusetts does not have a county infrastructure. We have 351 independent jurisdictions that are responsible for following up on those infectious diseases, except for sexually transmitted infections, which are done only at the state level. And so we have developed a infrastructure, which we will be describing to your surveillance infrastructure that supports the work at the towns and at the state level to do the investigation of those diseases. My office specifically is the Office of Integrated Surveillance and Informatics Services, also known as ISIS. We were first, but we do get a few jokes about that. We are epidemiologists, informaticians, biostatisticians, and research analysts. And we have subject matter expertise in core epidemiology and surveillance. And we have epi liaisons to each of the different programmatic areas within our bureau. And we work very closely with Katie as our state epidemiologist. We also have informatics expertise, and we oversee a system that's called Maven, which is the Massachusetts Virtual Epidemiologic Network. That is the state's surveillance and case management system that's used by state and local officials to do follow-up for those diseases. And we're responsible for making sure that the configurations meet the needs of the epidemiologists and the public health nurses. And then we oversee a lot of the big data systems that bring the data in electronic laboratory reporting, case reporting, and syndromic surveillance activities. We're responsible for making sure that case definitions are being applied properly and making sure that standards for data collection meet all of those needs. We also report up to CDC as part of the national surveillance reporting infrastructure. We send daily and weekly feeds of de-identified data up to CDC so that they can present those data in the MMWR and in other modalities to provide a national picture of what's going on for the notifiable diseases.
I'm curious about that step. Is that, did someone send an Excel spreadsheet, or is there an automatic infrastructure
That's
that
a
just...
great question, and the answer to that is yes and yes. So CDC has been working on what's called the national, the NEDS Modernization Initiative, their surveillance, National Disease Surveillance Initiative, to improve messaging between states and CDC. To send all of the data in a standardized message format automatically. They're not quite there yet. They are going disease by disease, and we are submitting what are called message mapping guides to get the data up there. We do send data in spreadsheets. We do fax them information. We do submit information through a web portal. So it goes in a variety of different formats, but we are working towards a more standard messaging capability. So.
Interesting. So you work, that's the CDC's work in conjunction with the states.
Yes.
I see.
Yes.
Okay. Interesting.
And then my group also triages all of the surveillance data for our bureau and for the local health departments. We make sure that it gets into the system properly, do all the quality assurance on that. And then we do and perform a lot of data management activities around identification of persons and disease information, quality assurance activities. And then we work really closely with different program areas, disease trends, and do routine surveillance work. So I'm going to pause there and let Katie introduce herself.
Okay, but can I ask a question right before that? That information comes from the towns, or does it come directly from hospitals, or both?
So
all of the above.
Yeah. So,
okay. All right.
So I can speak a little bit to that. Gillian, can you go back to the bureau structure slide for a sec, please?
Thanks,
Right.
Gillian. And go ahead and introduce yourself.
Yeah.
Sorry about that interruption.
No, not at all. So I wanted to provide a little bit more context for how and where ISIS sits in the structure of the Bureau. And in many ways, I actually think this should be a circle with ISIS in the center and then the different divisions and offices coming off of it. So in general, so with the exception of the State Public Health Laboratory and then the Office of HIV/AIDS and Office of Healthcare Planning, everything else is, the reportable diseases are divided up, and the epidemiologists who do focus on case investigation and some of the data reports sit in the different divisions. So epidemiology division has, the largest number of diseases. Division of Global Populations has tuberculosis and refugee and immigrant health. We have the Office of STD, Division of STD, which is where all of the surveillance activities for the STDs and HIV sit. But ISIS manages the data for all of those things. And the reporting streams are many and varied. So the regulations actually are that reporting is supposed to be by both clinicians and laboratories. But in practice, most infectious disease reporting starts with an electronic laboratory report. And that electronic laboratory report, and the reason it starts there is because it's an electronic system, it's automated, right? So a positive result for, say, salmonella automatically comes in through ELR, electronic laboratory reporting, into the Maven system, and that result is seen immediately by both the epidemiology division, who has responsibility for it at the state level, but also the local board of health in the city or town where that resident lives. And so that's sort of where everything starts. And then information from clinicians or the patient is obtained often by the local health department, but sometimes by an epidemiologist working, again, in this case, in the epidemiology division. So
these are, you say clinical laboratories, you mean like in hospitals, big hospitals have their own and they send them to you. And I guess there's also private, smaller ones where doctors sometimes ask them to do it for them. And does this mean that to have a lab to run these tests, you have to have this connection to the Massachusetts epidemiology department? You can't run a lab without that, like a clinical lab?
Well, so you are required to report it to the state.
I see.
The mechanism by which you report it,
It's supposed to be
it's supposed to
through,
be, yeah,
it's supposed to be electronically. That doesn't always happen in practice.
right.
I see. So you get phone calls or emails and like that's
Pieces
got
of
it.
paper.
Oh my. Okay.
Yeah.
Yeah, and it's high volume too. I've got another slide in a little bit that talks about the volume here. So we
Wait,
were.
I'm sorry.
Go ahead.
I just want to explain where state epidemiologist fits into that whole structure. So, you know, Gillian and I are both epidemiologists by training, right? But in our jobs, we rarely get to do epidemiology. You know, but the two roles are tied very closely together, hers and mine, where, you know, the state epidemiologist works with everybody, but particularly the director of ISIS, to make sure that the surveillance systems work and that they make sense and that we're, you know, collecting the data that we need to collect and reporting to CDC appropriately. But this also involves making policy decisions about how to obtain data. You know, what are we willing to live without? What do we absolutely need? You know, all that sort of stuff. And so unfortunately, she and I often, or fortunately, it's where we are, right, end up doing a lot of these sort of policy discussions and then having the epidemiologists and the informaticians and the biostats people kind of then they get to do the fun stuff, right? Right, Gillian?
Yes.
All right, now you can go back to the laboratory reporting.
All right. So so I have been working at the lab for about 20 years, and in my current position, or sort of current position, for like the last 10, 15 years. And we when I started there, we were primarily paper-based, like faxes, mailing reports out to local boards of health so that they could do the case investigation, running paper up and down the hall to the EPIs so that they could follow up. It was a nightmare. And after 9/11, we received a lot of funding from CDC to establish an infrastructure that would really automate a lot of these practices. And so that's when we started building Maven. And so Maven is, as I said, is our surveillance and case management system. And we've spent the last 12 years building it up so that it is fully integrated across all notifiable infectious diseases, reportable infectious diseases, and that it is able to have a supporting infrastructure that will automatically feed data into the system.
And you do that. You decided to do that. Your office decides to do it. It's not a mandate from the federal government. It's like they tell you you have to get these things to us, so you decide. Well, then we need to build a system, and you just do it. There's a lot of. I guess what I'm asking is there seems to be a lot of initiative coming from within the state. So say Mississippi, Alabama, Alaska might be completely different. They might not have any of this. Is that fair to think is a possibility?
I think the robustness of different states' surveillance systems varies. We got out ahead, back 15 years ago by trying to develop this, and we wanted to do something that would be good for all reportable conditions and that would work for both at the state and the local level, because that would sort of give us economies of scale in being able to support this. And then, the sort of joke around the lab is that I beg, borrow, and steal from every single program area because we are primarily federally funded. My office receives very little state funding. Most of our money comes directly from CDC, from the different program areas at CDC.
I see.
So we work with all of the different data partners. So all of the hospital clinical laboratories, we've spent years bringing them online to report diseases electronically through this. So, most of the laboratory information systems have, their standard set of laboratory tests and results that's in a coding schema that we need to be able to figure out how to, come into ours. And so we created this portal here that is an interface. It's like a mapping interface to take their data and to map it to our coding schema, which is the standard for laboratory data, and then to be able to bring it into Maven, and Maven actually automatically reads that test and the result and then creates a disease event and then triages it based on what disease event that is for the epi and locals to respond to.
Well, yeah, we call that data wrangling in our world.
Yes, it's a lot of data wrangling. And I'm just going to flip forward here in terms of the lab data. So pandemic, we were getting about 98% of our laboratory data electronically. And this constituted over 9 million lines of laboratory data. So, you'll get your initial result, you might get a speciation, you might get, additional, data about antibiotic resistance on a particular result. Every single line has to be reviewed and assessed and triaged. So we were getting over 9 million lines of laboratory data for reportable conditions before the pandemic hit. And we were set up to be able to manage that in, an infrastructural point of view. After the pandemic began in March, we have had to scale up with all of the different testing facilities, new testing facilities, pop-up testing facilities. And we went from receiving, in the neighborhood of several thousand results a day to, upwards of 18,000 results a day. So these are both positive and negative results that are coming into the system. So, the scale with what we're working with, just, it went up by like tenfold. And I have to say that the system has responded fairly well. We have an aging infrastructure in Massachusetts and state government, and we have a lot of old computer systems. We have problems with VPN, but I'm happy to report out that the infrastructure that we have had established has really managed the volume of information that's coming in. And of course, how we respond to that is really based on how good the information is coming in. So if a clinician, when they do a test order, doesn't give the patient's name, date of birth, address information, by the time it reaches us, if I don't have those basic pieces of information, I can't have it go through a deduplication process. And I want to make sure that, Gillian Haney's information is matched with Gillian Haney's information. And what we're seeing right now is a very, we've really tried to work really hard with laboratories and clinicians to make sure that they do send us complete information. But when they don't, it creates a duplication process that is very difficult to reconcile. And I think that my favorite phrase is, in terms of data, is these data are current as of this date and this time. And as soon as I send them out, they're out of date. So the data are constantly being updated and cleaned and reviewed, and it's very much an ongoing process.
Interesting.
So I'm going to go back here to Maven here in terms of this is our surveillance system. So again, it's a single integrated system across 90 different diseases. We've achieved, it took us 10 years to get to full integration across all of them.
I've been tracking the data from Massachusetts pretty much every day, and I noticed that on I think it was May 31st or June 1st, there was a huge spike in cases. That can't be real. It must be something happening in the database. This is from the COVID tracking project. So I don't know, your database might be different, but is that something that rings a bell to you, that day
Yes.
Yeah. Oh, okay. So something did happen that day.
Yeah, I mean, that's totally an artifact of reporting, right? And so we have had several episodes with one of the largest national commercial laboratories in the US where reporting, because the testing volumes are so high, something goes wrong with their reporting to public health departments. And so those results end up getting batched, a week worth of results will end up getting sent on one particular day. It's one of the reasons I laughed, because that COVID tracker is reporting data by the day it's reported instead of by the day the case occurred.
Do they have a way of getting the case day?
Yeah, they could look at our data, which is what we put out every day because it makes much more sense.
What are they using then, if not your data?
I think they're literally just taking whatever it is that gets reported that day and they put it into that day. Instead, what we do is we take the the total number of people reported with COVID on June 30th, but we know that based on the day they were tested, they actually are were 5 days ago, and so we spread out all of those reports based on the day that the specimen was taken, which is a much more epidemiologically sound way to look at the data.
Okay, sorry. I know maybe you're not used to somebody asking so much about these kinds of questions, but I want to understand this. So they're getting the data from. I didn't get exactly the distinction. The COVID tracking project is getting the data from where exactly?
I suspect they're taking it from the first page of our dashboard. So
Okay.
I don't know if you all are familiar with it, but the first page just says, total number of new cases.
I see. So they just grab
reported
a couple of numbers every day and put it in their
exactly.
spreadsheet. But you have your own spreadsheet that you share, or something that you share. What is it? Is it a spreadsheet, or is it a API to your database? What is it?
It's a very challenging data wrangling process in order to prepare the data that get published every day. So I have 2 senior epidemiologists who do this full time all day. And they basically have to export the lab data as well as the epi data and then reconcile that information because the way the data are stored in Maven. And go through huge amounts of reconciliation and data cleaning, and to eventually produce data in a CSV format that can then be brought into the dashboard and displayed.
And is that CSV shared or no? That you keep that?
No, the CSV is posted online as the data behind the dashboard. We do not have like a Tableau system right now where, it just automatically displays the data. So we're still using a little bit more of a manual process.
Yeah, good. That makes sense. So COVID project, if you're listening, get that CSV file. Don't get the...
Yeah, it's right there on the website.
It is suppressed though for confidentiality. So in order to maintain patient privacy, we do suppress cases of less than 5 if they're in, if there is in a population of less than 50,000.
Okay. Got it.
So it does have that caveat to it.
Okay. Good. Thanks.
So I just want to quickly say that just a couple of other things about Maven in terms of triage is that it's a highly secure system because obviously this contains incredibly confidential health information about Massachusetts residents. And the security, you only get to see what information in the system you're authorized to see. So if you're a local board of health, if you live in Cambridge, you don't get to see any of Boston's data, and if and vice versa. You also only see diseases that you're authorized to see. So people who work in TB don't see, the zoonotic diseases, and STIs, no one sees STIs except for the people who are working within that division, and then it's not available also at the local level. So the data are very categorical in terms of what you have access to. We also have a pretty sophisticated deduplication system, and so Maven is a person-based system, which means that you and your demographic information are in the system once, but you can have multiple disease events associated with an individual. So this allows us to look at comorbidities. It can allow us to look at reinfection and so on and so forth.
What do you use for ID?
Names, date of birth, and then they get assigned a Maven ID in the system.
Okay.
So, we spend a lot of time looking at, so we also have for each disease, it has an associated, what we call an event time period. So it's a time period that's associated with that particular infection. And so if you get a new report that's outside of that infection, it would be considered a new disease event. So for a disease like hepatitis B, for example, you're considered to have chronic disease, right? And you don't get reinfected with it. So your event time period is infinity. So all of the laboratory reports or any type of information that comes in longitudinally about a person will all that'll all append into their specific disease event. Whereas a disease like salmonellosis, we put a time period in as 1 year. So if you get a laboratory report on, day 366, that would create a new salmonellosis event within the system. Right now for COVID, we are everything is coming into a single disease event right now, and it remains to be seen what event time period we will establish for that.
We have a question from the audience, is that if you can share the link to how to get to this data we've been talking about, or maybe something we could Google easily.
Sure, it's right on the massachusetts.mass.gov website, the dashboard, and COVID, just click on COVID and it'll take you right there.
Okay, thanks. So can I ask a question, since we've been talking about all this storing of information, I want to move the conversation along to how you use it. So do you use, so now you have this in COVID, well, we know it's here, but let's suppose it's not, and you're basically monitoring this, right? So to see if you should be worried about something if there's an outbreak. So can you say a little bit about how you do that? Do you use statistical models? Like what raises a red flag? How do you see? Is there a graph you're looking at, or is it some statistic, some test statistic? I mean, you don't have to go into too much detail, but just for us to get a general idea.
So Gillian, do you want to stop screen sharing, and I'm going to pull up the dashboard for a second?
Sure.
I know I just pulled it up. Hold on, I will find it.
So another question I have related is how fast do you think you can detect an outbreak based on whatever monitoring you do?
So, you know, the ability to detect an outbreak is all dependent on testing, right? And so testing is complicated, particularly in the world of COVID, because so many people are asymptomatic, and we know that transmission can occur both from someone who is entirely asymptomatic, but also people who are pre-symptomatic. And so we can't do what we normally do for influenza, for example, which is, test sick people. We have to do a combined surveillance approach where we are prioritizing testing sick people, making sure that their close contacts get tested, but also thinking about how to do surveillance in other populations so that we can make sure that we are looking for outbreaks kind of before they occur, or as they're occurring, right? And so surveillance for that is quite complicated. And while COVID was really common in Massachusetts, it was easier because more people were symptomatic. Right now, our percent positivity rate on testing is down in the 2% range. So our 7-day weighted average of a molecular test, we're down around 2%. And so as transmission is decreased, we have smaller numbers of symptomatic people, but it means we actually need to increase testing, right, to be able to detect even low prevalence. But I wanted to show you this because it was getting at some of the other questions that you had asked. So first, I'll go back. So this is the data dashboard. The URL is up at the top here. And so my suspicion is that the COVID tracker is just taking the data that's like right here on this first page and then on the second page. But if you actually, want to look at data over time, this is more what you're going to see. So remember I said, the number of cases that are reported today, let's say it's 100, but they're going to be reported from like over 5 different days. And so we would change these numbers each day based on the new results that we're getting. Gillian, stop.
You can see the weekend effect real clearly.
Yeah, really clearly. It's fascinating.
I've never seen that before. It's bizarre.
Yep. And so this is, exactly the same data. You can also see these were the 2 days where the state established pop-up testing in response to the demonstrations, and there was concern that maybe those demonstrations would have resulted in increased opportunity for transmission. So those are those 2 days where people could go and just get testing for free, right?
Yeah.
So you can see those testing.
So just so everybody's aware, that's testing, not cases.
Yes. And so then, the other thing that's been really interesting, right, is that people are getting tested, tested multiple times, right? So this is the number of PCR tests that have been done. So any person in the state who's had at least one molecular test. And then the next page is.
Okay, go ahead.
Yeah.
No, I have a quick question. So do you only report cases when it's a molecular test? You don't, the serological test, you don't consider?
Yeah, so it's a good question. So the way reporting works for reportable diseases is that there's a case definition that you apply. And so for COVID, the case definition for our confirmed cases, the ones that we, are very confident in, are people who have a positive molecular test, right? It indicates current infection.
And this is not the case. This is not uniform across states, is it?
Yeah, it is uniform across
states.
It is.
So all states are only reporting.
Well, no, wait, stop. Not only reporting, we're reporting these as confirmed cases, right?
So confirmed, okay.
So then so here's our data on antibody testing, right? And, the chart looks just as impressive, but the numbers are actually quite a bit smaller. The scale here is just, orders of magnitude smaller. But sorry, back to the beginning.
You got a lot there, huh?
Yeah.
So but can I go back to my I have some questions from the audience I want to ask. But
yep,
okay, go ahead, finish.
2 seconds, and then you can. So serology tests, positive serology tests, in a place where COVID transmission is occurring, essentially create a probable case. So we're less confident about those. The serology testing is just not as good. There are false positive, false negatives. It doesn't represent current infection, blah, blah, blah. So they're categorized in the national case definition as probable cases. But all of the metrics that we're looking at rely on confirmed cases, the ones that are, PCR positive, because that, again, it represents current infection.
Okay, thanks. That's good. That answers that question. So one question from the audience is if the cases went up after the protest. I've looked and they haven't. I don't know if you see something that I don't.
Nope, they did not. It was really impressive.
So yeah, it's outdoors. People were wearing masks. So the question I asked earlier, I still don't have an answer for it. Is like that I see all this, right? This is all very descriptive, but I did see some little green and yellow lights. Those, like, that must be based on some kind of decision. Is that a decision that's like based on a statistical model and a statistical test, like, or is it just you look at the data and make a decision based on what you see?
So it's not statistical test. It's really trend monitoring. It's looking at this particular slide, and there are tons of different models that have been created in Massachusetts. Obviously, we are rich with epidemiologists, and so we have worked with Harvard and Northeastern and anybody else who's chosen to put together a model, as well as the ones that are nationally available publicly, and looked at different models. But remember, the real point of a model is to be able to compare the effects of different interventions. Models are actually not meant to tell you like what's going to happen in 3 months. No. They're really designed to tell you how good is masking versus, what if I do masking? What if I do masking and social distancing? What if I do stay at home? And it's supposed to show us those differences.
So I'm sorry, I wasn't clear. I wasn't talking about mechanistic models. I was talking about statistical models to define what's outside of a normal range. That's what I meant. Like, because we will see variability, and you might have a peak that's due to noise, but then at some point we have to decide it's not due to noise, it's a real signal. So that's the kind of statistical testing I was talking about. Not right.
So, but a lot of those also require, those models also require what, historical data to be able to identify what is in excess of baseline. So we're able to actually, we do syndromic surveillance data, which is hospital ER data, chief complaint and diagnostic and diagnosis codes. And we do really good like ILI and flu surveillance data counted based on previous years that allows us to really to track what's happening and to, really identify when the seasons are beginning and when it's actually starting to fall off. When we're hoping to incorporate, we have started incorporating COVID-like illness into those models, and it seems to be tracking fairly well. I think it'll be quite useful in the fall to be able to see, if we're starting to see an increase again, and to be able to try to differentiate between that and influenza-like illness.
But it seems like it's using visualization. You just look at a plot and make a decision. You're not necessarily have some automatic limit detection. But I mean, I'm not criticizing. I'm just asking if that's what, because that's what
it's totally true. We don't at this moment, but I also think that we are only just getting to a point where that is actually going to be useful, right? Because because you need the historical data to be able to figure out what is a deviation, right? And things were changing so rapidly throughout most of the activity in Massachusetts that you couldn't, it wasn't useful to look for deviations using that methodology.
It's too noisy.
At this point, yeah, thank you. I think at this point we've sort of hit a little bit more of a steady state, right? We knew COVID was never going to go away. And so here's sort of, I think, what our baseline positivity rate is in this moment. And I'm just using positivity rate as an example. But so here is a place where we could actually, I think, start to apply some of what you're talking about, looking for increases that are true, statistical deviations. And I also think we're going to want to do it not at the state level, but at a more granular level as well. Because if you look at city-town data, it varies widely and dramatically from this 2%. So honestly, I think we're only just getting to the point where what you're talking about is going to be useful.
Okay, great. Well, we are over time, but I see that there's still a lot of interest. So if you don't mind, I'm gonna ask a couple more questions. If that's okay with you?
Sure.
Okay, so when I look at both the COVID mortality and the excess mortality for this period of March 15 to around May or June, you see there's a very heavy tail in the U.S. The distribution is very heavy tail, meaning that only a few states had very bad cases, and Massachusetts is one of them. It's like 8 states were really bad, and then the others weren't even that much worse than the 2018 flu season. But then the ones where it was bad, it was really bad. And I've also noticed that a lot of these are all of the states that have borders with New York were hit hard. So do you have, as epidemiologist, do you have any insights into this? Like so it was New York, Connecticut, New Jersey, Pennsylvania, Massachusetts. I guess Rhode Island wasn't that bad. And then you have Illinois and Michigan were also quite bad. So do you have an insight as to why it was like that? Like why were a small number of states hit so hard and then others not so much?
Gillian, do you want
I think it's really hard to compare across states just because there's such dramatic variation between, testing, population density, age populations in terms of who's being infected. I also, so it is hard to differentiate. I also think, and Katie, correct me if I'm wrong here, that I think that travel patterns from outside the US also really influenced,
I see.
Particularly on the Eastern Seaboard, how hard we were hit. So, there was a lot of focus on China, understandably so in the beginning, but, Europe started having a really big outbreak, and tons of people were coming to the East Coast from Europe. And so I think that was also something that helped really contribute to what we saw on the East Coast.
And how about bad luck with like retirement homes? Is that something that maybe also happened? Just a bunch of them got hit, and there was a really strong bad outcome.
Yeah,
given the age of the residents.
Yeah, but that's not specific to the Northeast.
Sure.
It's just that is a hugely vulnerable population, right? One of the reasons, so so remember that the way COVID gets into those facilities is through staff members. So you have to have community transmission in order to end up with long-term care facility problems. And because there was a lot of community transmission up here, we saw, you know, the long-term care facilities get hit very hard. But Washington State early on also saw that, and other states have also experienced it, perhaps at lower levels as their community transmission has been lower. But, you know, we could ask the same question right now about the southern states, right? As an example, like, why now are they being hit so hard? And it likely
I heard one theory that it's because they're going indoors.
Yep. I mean, I think that's absolutely part of it, is indoors is part of it, but it's not enough, because, you know, in the South, people spend a lot of time in the summer outdoors, you know, playing around.
Yeah.
And so it can't only be that. I think COVID gets into a location and burns really hot. But it, you know, it didn't do it across the United States all at once. And I suspect that unless we see really long-term immunity, which is quite questionable at this moment, that we're going to continue to see these hotspots pop
So
up.
on a somewhat related question regarding the spread in small areas. So at Farber, we have probably most of our employees use public transportation. We have no parking here, very little parking. So that's one of our biggest concerns of how we're going to deal with whatever reopening we do is, are people going to be comfortable taking public transportation to work? So can you share your thoughts on that? Is it going to be safe? Are we going to do something to make it safe? Should we be worried, not worried?
So I worry about public transportation because you're talking about, you know, large numbers of people in small spaces that are, you know, essentially indoors, right? A train, car, or a bus is sort of indoors. I think the question that has yet to be answered is, what effect does masking, you know, does close to universal masking have on transmission in those sorts of settings? And I don't think we know the answer to that yet. Aside from masking, I'm not really sure what the alternative is. I mean, the alternative is that we had more trains and we could maintain social distancing on the trains, but, you know, we know the MBTA, and that's not going to happen.
No. Yeah. All right. Interesting. Now, and what are we doing? Can you tell us a little bit about what we're doing now to, you already said a little about this with looking at the graph, but if you have anything else to add about what we're doing now to make sure that we detect a new outbreak if there is one, and that we keep it from happening.
Yeah, so the focus states got a fairly large influx of money from the federal government, and the purpose of it was largely to design surveillance testing, right? So, you know, insurance is going to cover the symptomatic people. In Massachusetts, they're going to cover close contacts, but they're not going to cover surveillance testing. They're just not. And so that's what this funding is for. And so the funding really just came through, but we are already well down the path of setting up surveillance projects. I say projects, that's not really right, but surveillance testing in Massachusetts. And I anticipate that you're going to hear a lot more about that, like, coming out in the next couple of weeks.
You heard it here first, everybody.
Yeah. Yeah, but I mean, so we're trying to identify areas where, you know, one, we already know that these are places that have been hard hit, so we're likely to find infections if they're happening. We're definitely looking at underserved populations, because you know, if people have been paying attention to the data nationally, we have seen that particularly Black individuals are quite impacted by COVID, and testing is not necessarily happening as much in either our Hispanic or our Black communities as it should be. And so that's another area that we're we're looking at focusing on, and then thinking about nationally what types of occupations and facilities have there been outbreaks in. So thinking in Massachusetts about our seafood processing plants as a potential risk, because we've seen the meat processing plants really have some explosive outbreaks. So, you know, thinking about all of those things and trying to come up with a cohesive surveillance testing strategy so that we can make sure that we're tracking things closely and carefully.
Thanks. All right, well, I'm going to ask you that one last question, and I'll start it with the question from the audience. So the question is, will we get aggregated data on the types of interactions associated with transmission? And you said a little bit about this, indoors versus outdoors, time, extent of contact, and then home versus workplace. And I already said that we'll be looking at different kinds of occupations. And then I'll let you answer that question, and then add, if you have anything to add to the audience of data scientists about how we could help, if there's anything we could be doing to help you, or if you're looking for people to fill in jobs, you can advertise it here, whatever you want to tell the audience. This is your...
Yes, I'm hiring. I've got lots of open epi positions. I'm desperate to identify qualified epidemiologists to come work with us. I literally have...
would you take biostatisticians?
Possibly, yeah. I have 2 on staff right now, so yes.
Okay.
So yeah, we're definitely hiring. I think I have 20 open positions to be hiring for. So
I would also say that I have been very interested in the sort of random outreaches I get from scientists who have looked at our data and then looked at other data sources that they know about that maybe I wouldn't necessarily think of looking at. So like some of this mobility data, which has ended up being pulled into the epi data to look at, you know, what effect did the stay-at-home order have, and where is our mobility now? Are we back to baseline? And we're not. Like thinking about kind of other data sources that might be important or useful, and then, you know, letting us know about them. It has actually resulted in some interesting findings, I think.
So you do find, that's good to hear that you do find that useful, and also that the fact that you make the data public, it lets others analyze it, and maybe there's some insights that you could use. So
exactly,
that's really great to hear.
Yeah, exactly. We don't think we know it all, and so we're always happy to hear smart and interesting and thoughtful comments from others. I will say that they're not always smart or interesting or thoughtful.
Tell me that. Yeah.
But when they are, I think they can be very helpful.
All right. Well, I gotta say, I feel better now than I did before. I based on this conversation, it seems like you're very competent and very much, you know, dedicated to getting this right. So thank you for that. Thank you for that work, and also thank you for joining us today and answering all our questions.
Thank you for the invitation.
Okay. Bye-bye.